Hello and welcome to a video on diverticular diseases. My name is Dr. Mona Panahi and I'm a Foundation Doctor on Lower GI and Acute Surgery. Diverticular diseases are a very common presentation in acute surgery. About a third of patients have them by middle age and 80% of patients over the age of 85 will suffer with diverticulosis. 2/3 of these are asymptomatic. However, due to their prevalence, it's important to discuss their pathophysiology, signs and symptoms, investigations, and importantly, management on the surgical ward. So diverticulosis is an outpouching of the mucosa through weaknesses in the muscular layer of the bowel. Patients will either be asymptomatic or have mild colicky pain. It's caused by lack of dietary fibre, where high intraluminal pressures can force the mucosa to herniate out. These often occur in the sigmoid colon, where the bowel pressure is highest, although in Asian patients they're predominantly right-sided. And diverticulitis and severe complications are more common in younger patients. Diverticulitis is when inflammation occurs, as demonstrated by more persistent pain and raised inflammatory and infective markers. We'll discuss diverticular diseases through the case of Mrs. T, a 68-year-old lady presenting to A&E, where you are assisting the surgical registrar and are asked to examine her. She has severe abdominal pain, worse in the left flank. This was previously intermittent in the past week and has become acutely worse and constant. When you ask about her history, she has had a few episodes of diarrhea and constipation in the past few weeks. In the past couple of years, she has experienced abdominal pain in the same location, but never as severe as this. On examination, at the end of the bed, she appears clinically unwell and is clearly in a great deal of pain. You examine her abdomen, showing guarding and tenderness over the left iliac fossa. She is febrile and tachycardic with a respiratory rate of 20. You do a PR exam showing very mild tenderness. Obviously, given the topic of this video, the patient has diverticular disease. However, going through the differentials of right flank abdominal pain, you should always consider surgical causes, including constipation, cancers, volvuli, previous surgery, inflammatory causes, including diverticular, history of IBD, and early appendicitis. For older females, such as Mrs. T, consider gynecological malignancy. In men, consider undistended testes or testicular torsion. Urological causes such as pyelonephritis, vascular pathology such as iliac artery aneurysms and ischemic colitis of the bowel wall in older patients, and soft tissue pathology which could be compressing on the surrounding nerves. Mrs. T with diverticulitis has a typical history. Pain can be constant or intermittent and associated with a change in bowel habits. Fever and tachycardia are common. If a patient has hypotension or shock, this suggests a complication. On examination, you'll find localized tenderness and you may feel a palpable mass. Bowel sounds can be reduced or normal. PR exam can be normal or reveal a soft mass for low-lying pelvic abscesses. Given that Mrs. T has had her baseline bloods, the best test for diverticular disease is a CT. A CT contrast scan would provide better information regarding complications of diverticulitis. In older patients where diverticular diseases and malignancy are more common, it's better to go for these rather than an abdominal ultrasound. For a diverticulosis without complication, bed rest and fibre, possibly with fibogel, can help settle symptoms. Oral mebeverine can help symptomatically. Mild diverticulitis is managed similarly, and patients can have oral antibiotics in the community. If a patient is very young or frail or has persistent pain, they should be admitted. Of patients admitted, most resolve with conservative treatment, but up to a third will need surgical intervention with a Hartmann's procedure. Complications include perforation. This can be a localized perforation which can be self-limiting, or rarely general intra-abdominal sepsis causing fecal or purulent peritonitis. Perforations are usually self-limiting, but they can have a high mortality rate. Abscesses can be treated with antibiotics if small, or if they're larger, a CT-guided drainage may be preferable to surgery in older patients. As with any chronic inflammatory condition, fistulas can occur. Obstruction or ileus usually improve following resolution of the inflammation, but surgery may be required if malignancy can't be excluded from the differential. You can have large amounts of PR bleeding, particularly with patients who are smokers or on anticoagulants. 80% of these resolve spontaneously but may need embolization or surgical resection. And the overall prognosis depends on the severity and inflammation. Which of the following patients with diverticular disease is least likely to require surgical intervention? You can pause the video now. The answer is our 68-year-old lady, Mrs. T, who can probably be managed on the ward with conservative management of fluid and IV antibiotics. The first option is a young 32-year-old gentleman, and as we discussed, patients who are young are more likely to have complications of diverticulitis. The second lady has a colovaginal fistula. This will require surgical resection and surgical repair of the vagina. The third option is a lady who has undergone chemotherapy. Patients who are immunosuppressed are more likely to present later to the ward. This means they're more likely to have prolonged diverticulitis and complications from this. They're also less likely to self-limit the progression. An argument could also be made for option D. However, 20% of patients with hemorrhage don't self-resolve and do need intervention. So to summarise, diverticular disease is a common presentation on the acute surgical ward. It's good to have baseline bloods and, just in case, prepare them for surgery with a group and save and coagulation screen. A CT scan is diagnostic in acute surgery. Diverticulosis can be also found on sigmoidoscopy or barium enemas, however they're not usually used in an acute setting. Diverticulitis is often self-limiting and can be managed both at home and on the ward, usually with cephalosporin and metronidazole. Surgical intervention is needed for younger patients, older patients, and those with complications listed below. Here are some sources if you want further reading. And thank you for listening.